And first off is Dr. Peter Lee, who comes to us from the City of Hope Comprehensive Cancer Center, and he has the wonderful title of Billy Wilder Endowed Professor of and Chair of Department of Immuno-Oncology, is also co-leader of the Cancer Immunotherapeutics Program at the Cancer Center, and Dr. Lee is trying to rationally integrate immunotherapies into the combinations to achieve proper treatment sequencing and maximum clinical efficacy. So Peter has also been a very generous contributor to BD with his expertise. He has beta tested a number of technologies, so he's been a known entity around here. Thank you, Peter, for joining us.
Thank you, Rainer. Thank you, Rainer, for the kind introduction and the invitation. And Smita, it's great to be here. I feel like I'm seeing old friends. I'm a big fan of BD, and I want to continue really working together on developing new technologies and using them for new applications. So I'm going to talk about how we're trying to link what's happening in tumors with what's happening in peripheral blood. And we're going to be using a few different technologies to try to get there. So, of course, cancer research has almost always been about the cancer cells. Everybody's just cares about what's happening inside the cancer cells and developing drugs against cancer cells. And we now know that most human tumors are about 50% cancer cells. So the other 50% of cells in tumors are other cells. And so we now finally realize that those other cells are important. And so this is just a cartoon to illustrate that there are fibroblasts and other stromal elements in tumors that play a very important role, and also immune cells. And really it's the interplay between all of these cells together that really drive clinical outcome as well as response to therapy. So we're very interested in not only studying one component, but studying the interplay between all the components. So as many of you know, there's been a huge interest in the immune system in cancer over the last less than 10 years. I've been interested in cancer immunology and immunotherapy for over 20 years, and I would say for the first 10, 12 years of my career, I've been laughed at, pushed out. People basically just thought that I was stupid or crazy to even think about the immune system in cancer, but now everybody's come around. So this is a fairly recent review summarizing, at that time, papers that looked at the prognostic significance of different immune cells in tumors. And so each N here is just one paper. And so this is just a summary to say that there were, at the time of this review, 19 papers on B cells, 16 on NK cells, etc. And the black bars suggest that those papers suggest that the B cells have a good prognostic significance, and the gray one means poor. So as you see, there are lots of papers, first and foremost. Most of them focus on CD8 T cells. Most of them show that there's good prognosis when tumors have these cells in them, except for macrophages when it's basically split. And that's because macrophages could be divided at least into M1 and M2. And when the papers did that, they showed pretty much that M1s are good guys and M2s are bad guys. So this is just as of 2 or 3 years ago, but there's a lot more data now than then. So one of the things that we do in my lab is we do a lot of tissue analysis, and we're very interested in not only numbers, but spatial patterns, and Ryan and I were just talking about that. So it starts with high dimensional staining, and we primarily do about 8 color staining right now. As many of you know, there are lots of technologies to go up even higher, but just like Ryan and I was talking about, you have to strike a balance. If it takes you 3 months to generate one image, it's probably not that helpful to study a lot of samples. So we took a middle path where we scale to 8 colors, but we can do it pretty rapidly. We can do one batch in about 2 or 3 days, and each batch we can do about 20 slides. So it's a reasonable throughput to get to some good data. So we used a spectral imaging system currently marketed by PerkinElmer. I wish BD have something for us to use. There's quantitative image analysis, and that's really important. So we don't want just a poor graduate student with a clicker and a microscope counting cells anymore, because one, that's inaccurate. Two, that's just impossible to count all the cells on a slide. So there's now a lot of machine learning algorithms to help us extract information directly from the images, and so we do a lot of that. And importantly, that not only gives us accurate counts of the cells and identify each cell based on markers, but also gives us an XY coordinate of each cell. And so we can do some very interesting spatial analysis as well. So it's, in a way, a little bit like flow cytometry on tissue with coordinates too. So I just want to show a couple examples. So this is a 7-color panel that we routinely use looking at T cells, B cells, and other cells. And this is actually a fairly unusual case where you see basically every kind of cell in the tumor. And the cancer cells themselves are stained by pancytokeratin. So those are the kind of the, I don't know what color it is, dark burgundy. But you see a commingling amongst almost all the immune cells with cancer cells. This is actually fairly unusual. But the other point that I just want to bring up is that tumors are heterogeneous. So if you look at a low-resolution image of a tumor section, each one of these boxes is a high-power field. So you look at this high-power field, looks like this, with very few cells, and certainly very few immune cells. And you look at another high-power field, which is actually the one that I just showed you, there are lots of immune cells. So that really taught us that there's heterogeneity, spatial heterogeneity within tumors. There seems to be areas where immune cells tend to congregate and other areas where they don't. And so we're trying to understand the basis for these regional differences and trying to also image and analyze entire slides. Because before this, most people only would analyze 5 to 10 high-power fields per slide and call it a day. And I would argue that's really missing a lot of information. But going beyond the tumor, where do the immune cells come from? And so now I view that the tumor is almost like the front line of a battle. And the troops, the immune cells, come from somewhere else. And I think most likely they come from lymph nodes, the draining lymph nodes. And so we're very, very interested in studying draining lymph nodes from those same patients and trying to really match what's happening in the tumor with what's happening in the lymph node. And again, that's looking at the immune cells in the lymph nodes, not just for presence or absence of cancer cells, which is what routinely is done today in clinical pathology. And also, we also want to ask, how do they go back and forth between these two compartments? So there's the lymphatic system, where we know that tumor antigens are shed and also certain antigen-presenting cells traffic, but that's, of course, also blood. And so the third component that we study routinely is the blood, to try to complete this journey, try to understand how cells go from one place to another and how do they change in the process. So we've been studying immune cells in tumor-draining lymph nodes for many years. And of course, recently, most patients only get sentinel lymph nodes removed. Sentinel lymph node is just defined as the first lymph node that drains a tumor. And that's identified by injecting either a radioactive tracer or blue dye into a tumor and then tracking that to the first draining lymph node. So that has a lot of prognostic significance. But we wanted to ask, what are the immune cell changes in these sentinel lymph nodes, and do they have prognostic significance. So we've looked at a lot of different immune cells in sentinel lymph nodes, and the assumption is that primarily it's going to be T cells that drive prognosis, because that's really what seems to drive prognosis in tumors. But what we found was that actually B cells have even higher prognostic significance than T cells in sentinel lymph nodes. And so here's just an example where we took this is a case control study where we selected about 20 patients who had good clinical outcome as defined by having had no recurrence for at least 5 years or longer, and poor outcome as defined by patients who relapse within the first 3 years. And so we just wanted to ask, are there differences in their sentinel lymph nodes? And the signal that came out the strongest were the B cells. So here, the good outcome patients had significantly higher B cell densities than those with poor outcome. And then if we set a certain threshold and do Kaplan-Meier analysis, we can predict clinical outcome pretty well just simply looking at B cells in these sentinel lymph nodes. So we recently, well, actually this is just coming out next week, I think. So another example that I want to show, the dendritic cells. So they're important too, but they're important in a different way. So here's where spatial analysis comes in. So what we found is that there are numerical changes in dendritic cells in draining lymph nodes, but more importantly, there are spatial changes. And one thing that we've seen consistently is that dendritic cells form these clumps, which we call clusters. And in fact, when we look at healthy lymph nodes, we find that most dendritic cells exist in these clusters. In fact, we quantify these clusters, and about 90 to 95% of dendritic cells in healthy lymph nodes form clusters. But in tumor draining lymph nodes, we've saw that the dendritic cells are less clustered, and in fact, some lymph nodes, we find that they're not clustered at all, they're just scattered. So as if some process caused these dendritic cell clusters to just disperse. And when we looked at just the degree of clustering of dendritic cells, we saw a very nice correlation with T cells and tumors, so as shown here. So the more clustering there is in dendritic cells in the sentinel lymph node, the more T cells there are in the tumor. And also, the better patients do. So there's also clinical outcome prediction. So that's also led us to now understand that dendritic cells in lymph nodes need to cluster. And there's some old literature to show that when dendritic cells cluster, they pass antigen, cytokines, growth factors back and forth. They're much more efficient in driving immune responses. And there's some more recent data showing that they also exchange antigens. And there are actually mixed dendritic cell clustering. And this is something that's fairly new in my lab, is that there are migrating dendritic cells that come from tumors, but there are also resident dendritic cells that stay in lymph nodes. And they actually get together in these clusters and exchange information and things like that. And so that's a very interesting direction that we're heading in my lab, is to understand this clustering process and how to regulate it and things like that. Now to the main topic of my talk today, which is how do we connect what's happening in peripheral blood to what's happening in tissue. Of course, the peripheral blood is the most accessible compartment, and also BD has developed some tremendous technology to interrogate what's happening in the peripheral blood. There's really no clear difference between good and bad outcome patients based simply on numerical differences. So we knew that we have to go beyond numerical changes, and so we wanted to really go deeper in understanding functional differences of immune cells. And of course, one such possibility is immune signaling, and using fossil flow and other techniques, and BD is really a leader in that. And so we've been doing a lot of phospho-flow and other signaling assays on peripheral blood cells of patients. As you know, cytokines mediate cell-cell communication, which really is critical to drive immune responses. And a lot of the cytokines signal through the JAK-STAT signaling pathway. So this is just in a cartoon of the interferon signaling pathway. So most cytokines bind to surface receptors, and then that binding triggers some phosphorylation events, generally involving JAKs and then STATs. And then once that happens, then these translocate to the nucleus and turns on transcription. So this is an example of interferon type 1, which is primarily interferon alpha, and interferon type 2, which is interferon gamma. So by using phospho-flow technology, we can look at the intermediate, in this case phosphorylated STAT1, as the reflection of what's happening in these signaling pathways. So we started this over 10 years ago. And so this is one of some of our older work, almost 10 years old, looking at signaling of interferon, either alpha or gamma, in peripheral blood T, B, and NK cells. So again, this is peripheral blood immune cells, not cancer cells, and not tissue immune cells. And we want to know, are there signaling changes between healthy individuals and patients with different types of cancer? And in fact, in looking at a number of samples of breast cancer, melanoma, and GI cancer, we saw pretty much the same thing as shown. So T cells, B cells, and NK cells have significantly lower signaling responses to both interferon alpha and interferon gamma. And, and as you know, interferons are very important master regulator of immune responses. So the fact that these signaling pathways are blunted suggests then that they have blunted immune responses. And we went on to show that there are a number of downstream signaling and functional abnormalities. So over the last few years, we've been going beyond interferon, looking at other JAK-STAT signaling pathways as well as other signaling pathways. So here's just a cartoon of some of the other JAK-STAT signaling pathways. So we've been studying IL-6 quite a bit. IL-6 is another very important cytokine in context of cancer. We have also found that in cancer patients, and here on it's mostly breast cancer, which is what I work on. So in breast cancer patients, their peripheral blood T cells have lower signaling to IL-6, both in phosphorylation of STAT1 and STAT3. And this is not just due to serum levels. So a number of studies have shown that there are elevated levels of IL-6 in the serum or plasma of patients. But in our cohort, we happen to have a cohort that had reasonably similar IL-6 serum levels. And when we looked at serum levels to signaling, we found that there's no correlation. So this signaling abnormality is not just a reflection of the levels of the cytokine itself. But more importantly, we wanted to see if they have any prognostic significance. So we simply divided patients into an upper half and a lower half. So patients that had upper half of the signaling to IL-6 did very well, in fact, zero relapse over time, whereas all the relapses happen in patients with the lower half of IL-6 signaling. So I want to remind you that this is blood drawn at diagnosis, and patients are relapsing or followed for 5 to 10 years. So somehow, something that we can measure in the peripheral blood at diagnosis seems to predict what may happen to these patients 3, 5, 10 years later. So I find that very interesting and exciting. So we also now are looking at other signaling pathway and also, as I mentioned, trying to understand what's happening in tissue in relation to what's happening in blood. So I'll give you 2 quick examples. So one is on regulatory T cells, Tregs. So I don't have to tell you, and we have an expert here in the room. Tregs are very important in cancer. They do many different things, dampening an effective immune response.